We're taking this, 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 we're taking with a pinch of salt.
Like the song says, we're taking this with a pinch of salt. That is, we're trying to ask sensible, clinically relevant questions to provide you, our dear audience, with sensible, clinically relevant answers. My name is Andrej Kobernet, and you're listening to A Pinch of Salt, a new ERA podcast series. It is an honor and a privilege to have as our guest today Dr. Sandra Herrmann, who is a well-known expert in the field of onco-nephrology. Sandra, welcome to A Pinch of Salt.
Thank you so much, Andrea, for the invitation. It's a pleasure to be here.
We're excited too. The pleasure is all ours. So we'll be talking about immune checkpoint inhibitors in this podcast. I'm always a bit surprised to find that the universe is organized in a very neat way. That is that when anything works well for the heart, it also almost invariably works well for the kidney, which is great because if we had drugs that are great for the heart and terrible for the kidneys and vice versa, that would be a nightmare to consult this with cardiologists, nephrologists. Which organ is more important? What should we do? But luckily, we don't have that problem in, let's say, cardionephrology. But in onco-nephrology, it's not that simple sometimes. Immune checkpoint inhibitors are a new kid on the block, maybe we could say that. Not so new, but still newish. And they might do wonders for cancers, but might be bad for any other organ, basically. They work by unlocking the immune system and just unleashing it. And because malignant cells are recognizable by the immune systems, they suffer because of it. But they also might cause autoimmune diseases. So because this is a new thing and most of us don't have a lot of experience with that, we'd like to ask you, Sandra, a couple questions that are just basically from regular clinical work, our regular consults with oncologists, I would say. Are you ready?
I'm ready. And as you say, it's not that new, but you are surprised how many people don't use that much and, need to have those doubts and questions answers. I think it's a great opportunity for that.
Exactly. Like anything in medicine, you need experience. And if you don't have it, things become difficult. So because these diseases can cause autoimmune diseases or can cause a flare of an autoimmune disease, the first question is related to one of our typical patients. So let's say we have a patient with known autoimmune kidney disease, for example, IgA nephropathy. This patient has cancer and an indication for immune checkpoint inhibitor treatment. So a type of cancer that would be where this treatment would be indicated. Can treatment be started in this case, even though the chance of a worsening of the kidney disease is probably significant? And if it is started, how often would one check kidney function and urine in such a patient?
Yeah, I think in those for this kind of patients, obviously there is a multidisciplinary decision among the oncologist, the patient, yourself. But if it's a life-saving therapy, and it's likely to the treatment we carry out and go ahead. So we discuss with the patient, and there is a chance of relapsing. When you get all the rheumatological disease, approximately 1/3 of them might have some flare, and probably the kidney is the same. We know that some patients might have some baseline GN, and you don't even know, and IgA is common like that because, some can be very mild, but they definitely can be carried out, and patient can receive the proposed treatment. But then you would require a closer follow-up. You would start the patient on the immunotherapy, follow closely. They usually come every 3 weeks for most of the treatments with checkpoint inhibitors. You can check the kidney function the following week. But most of the time, if it's doing okay, every month, those patients will be followed with laboratory. And then if there is some significant, change of kidney function, flare, or the urine analysis get more, active, then you might be concerned that's really flared up. And they, most of the time, those patients, if they have a specific disease that you already know, most of those patients, they will receive a dose of corticosteroids because, it could be, if it's early on, most likely could be a reflare. If it's around the time that, interstitial nephritis was the most common pathology found, between 12 and 16 weeks, they also can get the prednisone for the treatment. If you know they have some particular disease that's not responded to the treatment, like membranous nephropathy, or some patients have a paraneoplastic disease, some IgA vasculitis type, you may use another type therapy for membranous. For example, rituximab has been used, and for case reports have been shown to respond. So to summarize, the treatment for those glomerular diseases that develop during the flare, during ICI, acute kidney injury, it will require specific immunosuppression for each type of disease. If you already know, you might need to go beyond the prednisone. In a systematic review done previously, corticosteroids was the mostly common use, at least for the beginning. If they don't, resolve, some might have used rituximab, some even cyclophosphamide have been used. Most of them would have partial or complete, at least partial to complete response.
Okay, so it's probably 1/3 of the patient. It's not every patient with already known autoimmune kidney disease. That is obviously good to know. And then, but the follow-up is quite labor intensive. If I understood you correctly, every couple of weeks in the beginning and every month after that.
Yeah, if things are going okay, if it's not flaring up, it's just because they have to come back for the have received the immunotherapy. So you check a complete, chemistry panel, so you can go for that. If the patient's doing fine, obviously you can come as regular with the immune checkpoint therapy. But if patients, we always say that I develop some, edema, some swelling upper legs, that your urine is more foam or something, it's good to alert the patient to be paying attention in those symptoms and find this they might need to come early on. But I think if you do a first time this patient, probably in the first month, I would do maybe the first week, then a couple of weeks when they return. And then if things are okay, probably every time with the ICI therapy.
So I guess a lot of this follow-up is then done by the oncologist, actually.
Yeah, I think in the first month, I think you wanted to be close. At least I particularly like to, you do labs, send to like this. If they live in another town, they send to us. If they come here, they do. And then usually we receive the alert and we check and follow up with the patient. And then if it's a couple of weeks and they're doing fine, they come, they get the ICI therapy. And with prior to receive it, they have the blood work and also urine analysis, and we can decide about if they're going to be receiving the dose or not.
Okay, so the second question would be related to a patient who's already receiving immune check inhibitors and has a worsening of kidney function. Now, this happens in about 5-10% or even more. It depends on which data you look at. It's certainly not in everybody, but it can also happen pretty late, 12 weeks, 16 weeks after the start, even after the finish. So when we do find an acute kidney injury, what is the next step? Presumably the oncologist finds this actually, especially later on. So can the oncologist give steroids empirically? Should this be done by the oncologist? Or when do you decide to do the biopsy? I guess they probably ask you to consult with you before they do anything, right?
Yeah, yes and no. If the most time they get the laboratory, if the kidney function is worsening, the renal analysis has effect. If there is no other cause, the patient, come, for example, very clean, melanoma has no other disease, or squamous cell, no prior diseases, and then he's just used or she is just using immune checkpoint therapy, and there is no other patient relatively drink well or think they can give some fluids and see if it doesn't, and there is no other cause due to ultrasound, there's no obstruction, sometimes and sometimes they live in a region that cannot get the nephrologist right away. They can go empirically treated with prednisone. That can happen. But as I discussed this prior, nowadays most of these drugs have been used with other nephrotoxic drugs like cisplatin, carboplatin, and VEGF inhibitors. So it gets more complicated, as you said. Then they will contact us and see what we think. After rule out other cows, they did ultrasound, imaging studies, they have a PET. You can consider, like for us, we use the biomarkers like CRP, which is a very common, C-reactive protein, can be used if it's elevated, might be a sign of immunorelated, inflammation status. We use retinol bind protein to creatinine ratio. If both are high and, and there is no other cause, we can go ahead and may consider empirical treatment prednisone. If it's very high, there are other drugs involved, there is a potassium, then we would go for kidney biopsy, especially if creatinine is elevated more than 1.5 to 2 times the baseline. And there were other PPIs or NSAIDs. Obviously, you hold everything and consider a treat with prednisone. If that's a clear cut. If not, the biopsy will tell you, because the problem is those other drugs can cause kidney injury that you don't need to immunosuppression with counteract the effect of the immunotherapy. So
if the patient is receiving carboplatin and you just have acute tubular necrosis, then obviously that's a different story, right? That's the challenge.
And you don't need, and sometimes we can. Obviously, once the patient had a acute kidney injury, I usually recommend, it's just ATN from the carboplatin or for example, TMA from a VEGF. Let's wait. We stop them and let's wait to resolve the kidney function at least closer to baseline, And then if they need, sometimes they just start immunotherapy and then they hold to the carboplatin in those cases. At least you don't need to make the patient bound to corticosteroids for several weeks, and then you wait to resolve and they can get the checkpoint in the next month as they are supposed to be. So there is a few things to consider, but the oncologists, they can treat if they are very sure that that's related to immunotherapy, but if they are not, they usually contact us and we go over.
So, and in this setting, in this group of patients, you find that CRP is quite good at discerning if the renal adverse event is due to inflammation or not. Because generally speaking, in acute interstitial nephritis, which is not related to immune checkpoint inhibitors, the CRP could be normal. But in these cases, it's usually elevated, right?
Yeah, that's a good question. In those cases, when the patient has the immune system bumped up and there is a lot of cytokine syndrome, like the release, they might have the CRP elevated. There's a caveat that some patients with the cancer, their CRP, like renal cell carcinoma, they have a better prognosis. CRP is high, so they might already have elevated CRP. So you have to those markers. I found, at least for us, is very helpful for patients with the AKI stage, 1.5, just like in the borderline, when you don't know if it's like volume depletion or maybe, as you say, carboplatin starting to act upon. In the first week, you already see some signs of that. And then you get the CRP and the retinol bind protein to creatinine ratio, they are normal. It's unlikely to see event that really cause damage, and then they'll be very helpful to say, okay, let's give some fluids, wait and check, come next week and see how other things go. If both are highs, then you might be helping help you to go towards to the kidney biopsy if the patient doesn't have any contraindication, obviously.
Okay, that's very useful information. So the third question. Now, let's say we have a patient who's had a renal adverse event. Let's say it could be let's say it was acute interstitial nephritis with this therapy. Now, but this therapy also is working great for the cancer, the melanoma, or whatever it is. And you want to obviously then continue with it. Can you re-challenge these patients with this immune checkpoint inhibitor, and when? Or can we do anything to prevent the next bout of acute interstitial nephritis? Does a dose alteration change anything, or do you just give maybe a low dose of steroids automatically if you re-challenge? What do you do in these situations?
Yeah, that's another very good questions. From the oncology, ASCO NCC guidelines, they don't recommend if anyone has their CTCA, the common adverse effect terminology of adverse effect cancer above 3, like stage, which would be equivalent close to our AKI stage 3. But other societies, oncological societies, they do recommend to re-challenge if the patient resolves the acute kidney injury, go back for closer to their baseline.
Yeah.
But a short answer, yes, you can re-challenge if this is really, a life-saving treatment for the patient, and the patient obviously recover kidney function, even though some patients, even if they don't recover and they prefer to be on treatment and maybe dialysis risk, they might opt, but in a great part of patients, you can re-challenge once the acute kidney injury resolved. There was this large retrospective study we were participated, where most of the patients, were re-challenged under lower dose of corticosteroids. In general, we use a 10 milligrams dose, which re-challenge to restart. And just 1 out of 5 of those patients, around 20% will develop the AKI again. It's important for those patients that you remove any potassium cooperative drugs like PPIs and SADs that may have triggered the AKI to begin with. And after you treat and get the prednisone, they're okay, the kidney function stabilized, then they can discuss with oncologists that's really needed. Then you can start with 10 milligrams, the most common dose. Some people do 20 first week and then go ahead and keep the 10 milligrams for first month. You check kidney function. If the things are going okay, especially they have a drug that instigate the interstitial nephritis, you can try to drop the prednisone to 5 milligrams next month and go ahead. But many times what really happens, those patients, they have the already immune system so ramped up that even if you are on 10 milligrams of prednisone and the kidney function is stable, hovering around the baseline, it is what really prevent going out, that they develop other immune-related events like pneumonitis or colitis that start getting too much because they respond well. It's actually immune-related adverse events is a good thing, is associated to a better outcome.
Yeah,
because you want your cells to fall. So you don't want that to be flare up or really come in a full blown, but prednisone 10 milligrams usually helps. And I have patients spend several months or weeks, months on prednisone and receive it. So in summary, re-challenge has been done and many times use the same class as immune checkpoint inhibitor. If they were in 2 classes, CTLA-4 inhibitors or PD-1, PD-L1, sometimes they just use one and then they continue on the therapy as much as the patient is responding.
Great. Again, very, very useful information for all of us who don't do this daily. Now for possibly the toughest question, can immune checkpoint inhibitors be given to transplant patients?
Yeah, short answer, yes, it can be done. But most of the time, the oncologists, try to use anti-cancer drug that it really is not going to be doing the opposite that you want to protect the kidney, for example, kidney transplant, which is our case. But yeah, it can be done if it's the drug that you help. And this obviously is a decision with the kidney transplant team, with the oncologists and the patients to decide. It's around 30 to 40% the patients will present with some kind of acute kidney injury. Most times this is considered rejection, but sometimes you are surprised and can find ATN. This usually occurs much earlier than with the immune checkpoint in native kidney, usually like in 24 days is the median that they would develop either antibody-mediated rejection or a T-cell-mediated rejection. Most of the time when they develop, the patient, a great percentage will require, obviously, dialysis, renal replacement therapy, because, but there's the new studies, and this was, I'm just discussing what we had the data before, because many times the oncologists, when they had some AKI, they would remove completely the immunosuppression even before starting therapy, because they were afraid to counteract the effect. So that's the results we had until more recently. But there are studies coming from Australia. They did treat patients with nivolumab. They kept all the immunosuppression, and only like around 10% of the patients had the rejection. So if you keep them on their immunosuppressive therapy, most likely they have less chance to have rejection. And other groups here have done the treatment and changed usually the three drugs they use transplant, calcineurin inhibitors, mycophenolate, mofetil, and prednisone. Usually they remove the mycophenolate, they change tacrolimus to mTOR inhibitor, and can do a tapered dose of prednisone. And the group from Boston, Dr. Murakami, they have done this with a few patients, and apparently they have not had any rejection. She presented this data recently. So yeah, it's an option, but I would say, I think the first thing you have to go over, if the oncologist will choose, they usually do not choose that as a first therapy for obvious reasons, but it can be done, and patients can be carried out.
Yeah, that mTOR strategy seems a promising one. I guess we'll find out more in a couple of years, when more and more patients might choose to, transplant patients that is, might choose to take these drugs. Yeah. Okay, so on to the penultimate question. So you're an expert in this field. You've been following it for quite some time. And if you had the chance to give only one message to a young nephrologist, what would that be?
Well, in relation to onco-nephrology, it's a expanded subspecialty that deals with a lot of intersections with the hematology, oncology, that's just growing up. And especially with these new therapies, this cancer immunobiology, and the mechanism, how these drugs work, and their toxicities that can, even though they target the cancer, they can have off-side effects, include the kidney. So it'd be very important for all nephrologists, the new or even as the old nephrologists, to really be up to date with these drugs, because if you see, you'll be almost 1/3 of the patients in general nephrology, they're going to have some kind of oncological issue, either related to the cancer disease affect the kidneys, or the drugs to treat the kidney disease. And because people are surviving more, and we have to deal with the complications of the AKI, they're going to develop, chronic kidney disease. And I think it's really important, even though it seems something very specific. I think more and more we're going to have to deal with the consequences or the improvement of the oncology and hematologists treating patients and then survive more, and then we have to help them to maintain the kidney health.
Yeah, so I guess the field is exciting because you can really do great stuff for the patient, particularly if the response to the cancer is good, which is often the case, and it's a lot of teamwork, which can be very rewarding. More people, the more people you have, the more knowledge you have in one room, I guess.
I agree. Yeah, it's oncology, hematology. We are very close, together. At least here in my division and my institution, we have very close contact with them, and that's very helpful.
All right. So the last question is a bit of a getting to know you kind of question. And this question is, which book, luxury item, and 2 songs would you take to a desert island, and why?
Well, I do like books. I'm not the most like fanatic for books, but there's a book that I like, The Outliners from Caldwell, and I would take to the island. I think it's a very interesting book. Help us to understand if we're working in something and invest in that can be helpful. And I think if I'm in a desert island and need the help maybe to get out, I would do that. And songs, I like the oldies. I like Coldplay, U2, and from which songs, I think my first time I listened Yellow from Coldplay was my I really started fall in love for the band. And U2 is U2, I think, and of their songs I would be happy to have with me.
I'm always kind of worried when these artists are considered oldies.
Oh, I think, I list them since I was like a teenager, very young age. And I feel like I'm already getting,
yeah,
if I feel that I'm old, I can measure for them, even though Coldplay is not an old band, but U2, yeah, U2 is, I would consider, what the Beatles were for me for probably when I was young, maybe U2 is.
Yeah, there's a whole generation that grew up with U2, and I know people that only visit U2 concerts and have visited 10s or 20 or whatever. So
yeah, I've been 4 times to show Coldplay 3 times. I love them.
Oh, Coldplay have crazy shows with all that light
Yeah.
work and everything.
Yeah, it's beautiful.
Perfect. All right. Sandra, thank you very much for doing this. Thank you for sharing your experiences and doing this podcast. Ladies and gentlemen, thank you for joining us and listening to this episode. Please check out other episodes that might already be available, and stay tuned for new episodes, which will be released every second Thursday of the month. Thank you very much and goodbye.